Hi, everyone. Thank you for joining us. For those who have not joined the other sessions, my name is Erin Foley. I'm co-president of National Adrenal Diseases Foundation, and I'm so happy to be your MC and moderator today. Next up, we have Dr. Geffner. Dr. Geffner has given talks for us before at NADF. Those are housed on our website. Dr. Geffner is a well-known, well-respected pediatric endocrinologist affiliated with both USC and UCLA Children's. And he is going to talk to us about adrenal insufficiency in youth. So with that, I'll hand it off to you, Dr. Geffner.
Thanks so much, Erin, and it's a pleasure to be here and to continue to serve your organization, which I think does great things. Alrighty, so whoops, a little too fast on the trigger here. So this talk is going to be about youth mostly, but before I can get into the heart of the matter, I just have to show you the requisite disclosure slide, which involves organizations, companies from whom I receive funding for one reason or another, but I assure you that none of that will have any bearing on what I'm about to say to you over the next 30 minutes or so. So I'd like to start the presentation with a case. This is actually the very first inpatient case I saw as a fellow way back, believe it or not, in 1979 when I was at UCLA. I learned quite a bit from it, as you will see. So this was a 2.5-year-old young boy who had had a history of 2 convulsions prior to the age of 2. In both cases associated with prolonged fasting, and one with a documented very low blood sugar of 28. He had had a 1-year history of skin darkening. When I saw him, it was actually at about 7 o'clock in the morning after he had been admitted the evening before in preparation for an evaluation, and my attending physician thought that he would have adrenal insufficiency, and she was right. And when I got to the bedside at 7 a.m., about an hour prior to planned testing, he was having a seizure. This was very nerve-wracking for me, and it limited my physical examination such that I could see that he was rather light for his height, and that his lips were dark. And ultimately, when I could look inside his mouth, as you will see in a moment, he had other signs of hyperpigmentation and also had these on other parts of his body, particularly his elbows and knees. So this is what he looked like over time, and I got these pictures after the fact, and you can see at 6 months of age on the left that he looked like a normal baby, basically, and particularly concentrating on the lips, which looked pink. And then by the time he was 2 and admitted to the hospital after we stabilized him, he was quite fearful and clutching his stuffed animal. But more importantly, you can see that his lips were hyperpigmented. And then upon opening his mouth, in addition to a better shot of the lips and their darkening, you could see a black deposit on his tongue related to his primary adrenal insufficiency. And his testing, when we were able to, be less nervous about his clinical situation, his blood sugar, it turned out, was only 10 milligrams per deciliter, which was extremely low and clearly the cause of his seizure. His sodium was also low at 123. The normal range of these tests are in the right in parentheses. His potassium was elevated to 6.2. And his 8 a.m. cortisol, which came back a little bit later, was undetectable, basically 0, and his ACTH level extremely elevated to greater than 2,000. This clinched the diagnosis of primary adrenal insufficiency and enabled us to develop a treatment plan for him. So why are we talking about this today? I think you all know, but I'll give you my take on this. First of all, the condition of adrenal insufficiency is not as rare as you might think if you count all causes. The symptoms are nonspecific, and these are a bit more of an issue in children, especially younger children who can't quite verbalize how they're feeling. And the diagnosis is frequently delayed or even overlooked. And untreated, if the condition is left to its natural course, it can lead to mortality. So a little bit about the background of adrenal insufficiency with an emphasis on the pediatric part of this. So primary AI, and you heard about this, the definition of this term, meaning the adrenal gland is where the problem lies, is rare in children. One study in Finland found a cumulative incidence of about 10 in 100,000 people around age 15 and 13 in 100,000 people at age 20. In children, the main cause are genetic defects, the most common of which, again, as you heard earlier, is congenital adrenal hyperplasia due to 21-hydroxylase deficiency, and this occurs in about 1 in 15,000 births worldwide. Now, central adrenal insufficiency, where either the hypothalamus or pituitary is at fault, regardless of age, is also rare. But most data on this come from adults, with about 50% of affected cases the result of a pituitary tumor or its treatment. And across all ages, however, the adrenal insufficiency that may occur in patients on low-dose glucocorticoid therapy chronically or who had been dose in the not too distant past that was tapered rather quickly, this can lead to adrenal crisis at any age. And this point will be dealt with in a little more detail in a bit. So another way of looking at the information presented earlier by Dr. Abraham as to what the adrenal gland does is depicted on this slide. And I'm not going to go into the same level of detail other than to point out that the adrenal gland sits atop the kidneys. So 2 kidneys, 2 adrenal glands. And there is an inner section here represented on the left by that red triangle, which is the medulla, and an outer section called the cortex, which is where the steroid hormones are produced, the medulla being the source of hormones such as epinephrine and norepinephrine, or adrenaline and noradrenaline. And the adrenal cortex, 3 major steroid compartments, basically regulate, if you go all the way over to the right, salt via the mineralocorticoids, of which aldosterone is the main one, sugar, which are the glucocorticoids, of which cortisol is the main one, and hormones related to sex, or male hormones in this case, such as DHEA and ultimately DHEA sulfate, as you heard about earlier. So in the way this axis, the HPA, hypothalamic pituitary axis, works, again, this is a little bit repetitive. I apologize, but some of you may have just come on for this talk, or maybe will, and those who will be reviewing the whole presentation later may just focus on the pediatric talk, so you will not have the luxury of the excellent introduction from Dr. Abraham earlier. But the hypothalamus in the brain produces CRH, which stimulates the pituitary gland to make ACTH, and the ACTH stimulates the adrenal gland to make cortisol. Cortisol regulates blood sugar, energy, metabolism, blood pressure, and the inflammatory response. It's produced in this diurnal or circadian manner in which the highest levels are between 7 and 9 a.m. and the lowest levels of the day between 12 and 3 a.m. Levels are increased during periods of stress under normal circumstances. The aldosterone portion of adrenal function is not under the regulation of the hypothalamus and pituitary, but rather under the control of a hormone called renin that's produced by the kidney. And this part of the adrenal function is responsible for maintaining or increasing sodium and lowering potassium and maintaining normal blood pressure. So if someone has primary adrenal insufficiency, if you move over to the right, where you see the components of the axis, that means, for example, that they will not make cortisol, as you saw it drop out there. And then if you go to the top, CRH will be made, and then following that will be ACTH, all in an attempt to restore normal cortisol, which may or may not be possible depending on the degree of adrenal dysfunction. For when the aldosterone drops out, then that is regulated, or an attempt to correct that is made by the kidney's production of renin, which goes up. For central adrenal insufficiency, again, this is a little bit of a repeat from what you heard earlier. There's two forms. There's the form where the hypothalamus is at fault, which is called tertiary, and then there on the right is the form that's related to pituitary disease, and that's called secondary. So using the same scheme that I just showed you a moment ago, on the left for when the hypothalamus is the problem, the CRH here will drop out. Then the ACTH will drop out. There will be no involvement here of aldosterone because that's controlled by renin. If you look over to the right for the pituitary form of central adrenal insufficiency, this will start by dropout of ACTH, which will then cause the cortisol to go out. But, and then the CRH will actually go up trying to fix this, but it can't. And then the renin aldosterone piece will be normal because, again, this is the central form, not the primary form of adrenal insufficiency. So a word about the causes of primary adrenal insufficiency with an emphasis on the pediatric causes, which will be highlighted in red as we go down here. And you'll also notice that the first letter of all of these different causes will be highlighted in orange, and you'll see a cute little acronym that develops here. As in adults, autoimmune adrenal insufficiency certainly occurs in children. There can be destruction to the adrenal gland through bleeding, as was mentioned earlier. You can see drugs meaning medicines that can cause primary adrenal insufficiency, some of which are used to treat adrenal excess Cushing's, but others are used to treat cancers, such as a new class of drugs called immune checkpoint inhibitors, and another new one called tyrosine kinase inhibitors. Then there's infiltrative disorders where things such as amyloidosis and sarcoidosis, sepsis, meaning infection, and tuberculosis was mentioned is still prevalent. And when Dr. Addison first discovered primary adrenal insufficiency, this was actually the main cause. That includes really genetic conditions, and this includes CAH, as was mentioned, and adrenoleukodystrophy, which is a metabolic disorder that was highlighted in the movie Lorenzo's Oil. If you want to watch that, bring tissues. And then neoplasm, meaning different kinds of cancers. So you'll notice the first letter of all of those spells Addison, and I cannot take responsibility for that, but it's pretty clever. This is Dr. Addison, who is a Brit who was born at the end of the 18th century and did his major work in the middle of the 19th century. And I always caution people not to confuse him with this guy, who's the gentleman of light bulb fame, whose name is Thomas Edison. Sounds alike, but obviously quite different. As far as causes of central adrenal insufficiency, again, with the most important ones in the pediatric age range highlighted in red for you, I will divide this into secondary or tertiary, meaning central, and then in a moment talk about drug-induced causes. But you can see there are genetic causes that actually affect the pituitary gland development, and on rare occasion affect just the ability to produce ACTH. There are brain tumors that are sometimes near, but not always, the hypothalamic pituitary region of the brain, the most common one of which is called the craniopharyngioma. There can be other pituitary tumors, although this is more common in adults. Surgery or radiation treatment of tumors sometimes can affect the hypothalamus. And then there's a long list there that you can peer at your convenience. And then as far as drug-induced, well, the glucocorticoid I mentioned is the most common, and this would usually be with oral, but it can be from other routes of administration, such as inhaled or intranasal, rarely from topical on the skin, and rarely from joint injections. And there are other drugs also that can do this, but I just want to say a word about opioids, which are obviously a problem in the United States, but have been clearly linked to central adrenal insufficiency. So how does one recognize adrenal insufficiency? In childhood, specifically the part related to cortisol. So early on, there are frequently GI symptoms, gastrointestinal symptoms, including loss of appetite, nausea, vomiting, abdominal pain, weight loss, and salt craving, if primary. There can be mental changes such as lethargy, apathy, and confusion. With stress, patients will often tell you they have an impaired ability to recover from what seems like a minor infection. If this is allowed to progress, the symptoms get worse and can affect one's energy metabolism, specifically the ability to protect against low blood sugar, thus causing fasting hypoglycemia, as was the case in my patient. There can then be cardiovascular or kidney issues, including inability to hold on to water. You pee out excessive water. This causes you retain water, I apologize, and this causes low salt levels in the blood, loss of blood pressure response to the stress-fighting hormone epinephrine, and ultimately hypotension and shock. If there is aldosterone deficiency, what might you see? Here, there's an inability of the kidneys to hold on to sodium. So the blood sodium level falls. This can lead to decreased blood volume, weight loss, low blood pressure, decreased heart function, decreased kidney function, kidney failure, and ultimately shock. And at the same time as the kidneys are losing salt, they're holding on to potassium and acid, and this causes rhythm disturbances of the heart. And then in the case of primary adrenal insufficiency, when the ACTH levels are high, there are other effects of that, as you can see here, related to ACTH and a sister hormone called MSH, or melanocyte stimulating hormone, which will be overproduced by the pituitary. And the ACTH, of course, is overproduced to try to fix the problem, although it can't. The MSH is a byproduct, and it stimulates, and it's thought to be the hormone that stimulates the darkening of the skin and mucosal surfaces, as you saw again in the patient that I presented. How do you diagnose adrenal insufficiency in children? The preferred way to start, as with adults, as you heard earlier, is with measurement of an 8 AM cortisol and ACTH. Sometimes this gives you the answer and other times it doesn't, in which case an ACTH stimulation test is the next sort of biochemical form of testing. And with newer lab methods, the cortisol level that defines normal in this test at any point during the test is above 14. It used to be 18 with older methods. And thus it's important for the doctor who orders the test to know which method is being used, because they're both out there. Other testing can involve a drug that's called metyrapone, which was off the market for a while, but is now back, although not commonly used. And sometimes it's done for you in the newborn period, where newborn screening is used to diagnose congenital adrenal hyperplasia, usually due to the 21-hydroxylase form. And in most states now in the US, the adrenoleukodystrophy, or ALD for short. The treatment of chronic adrenal insufficiency involves replacement of glucocorticoid, usually in the form of hydrocortisone. Now you'll see here a range of dose of 7 to 10. Earlier you heard 8, which is right in that range. And this is milligrams per meter squared per day. Meter squared is a measure of the surface area of the body. It's a little different than weight, although weight goes into the formula. And we usually give in childhood 3 doses per day, with half of the total calculation in the morning or upon our waking up, a quarter in the late afternoon, and a quarter at bedtime, to mimic the normal way the body does it. However, with one exception, that being CAH, where the dose that's required is usually about twice as much. And this is necessary because in addition to just simply replacing the lack of cortisol that the body makes, there is a need to fully suppress the excess ACTH so as not to allow the overproduction of male hormones, which can cause many of its own problems that is unique to CAH, but no other form of primary adrenal insufficiency. And this can be given either in a circadian, or what we call reverse circadian manner, where the highest dose is at bedtime. Regardless of the cause, if you can't make cortisol and you get stressed, you need more. And that's been made clear in the last two presentations. If you're not too sick and when I say you, I mean you or your child, can take their hydrocortisone orally for minor to moderate illness or trauma, but via injection with more severe illness and trauma, and if pretty much always if there's vomiting or at least more than one episode of vomiting. Most patients with primary adrenal insufficiency, nearly all, require mineralocorticoid deficiency in the form of fludrocortisone, the most common dose of which is 0.1 milligrams per day, interestingly, at all ages. And the home injectable glucocorticoid, which you heard quite a bit about a moment ago, should be in the hands of all patients or parents of patients. So when you take hydrocortisone, I just want to make a very important point. When you take it by mouth, this is what happens to it. And what you see here are cortisol levels on the left-hand side, which is the y-axis, and then across the bottom is time, starting with 0, which is the time you take a dose, to 6 hours later. And you can see the dose is at its highest about an hour to an hour and a half after you take a dose, and it gradually comes down such that there's none left at 6 hours. So in theory, it would be probably advisable to take hydrocortisone 4 times a day, but this is very difficult for people to do. Also realize when you take an oral dose, only about 70% or 80% is absorbed. So you have to take into account and provide a little extra when you do the calculation for body surface area, or you will underdose somebody. Now, just to make a point, this is what happens when you take hydrocortisone 3 times a day. And what you see here is, again, on the x-axis, you see a 24-hour clock from 6 a.m. to 6 p.m. And cortisol levels on the y-axis. And you see in the dark black line the normal levels of cortisol over the course of a day, highest around 8 a.m. and it goes down over the course of till midnight, and then it comes back up again. And then you see what happens when you take 3 doses of hydrocortisone, 1 in the AM, 1 in the afternoon, and 1 in the evening, denoted by the upside down arrows and the dashed lines reflecting the blood levels. And you can see that when you get to about midnight, there is no more medicine left across this whole period of time indicated by the red circle. So if somebody were to get a severe infection or, I don't know, some terrible trauma in the middle of the night, they would not have coverage. To get around that and to try to make, in general, the lives of children and patients with adrenal insufficiency better, there have been some new developments. So there is a product that's available in the EU, European Union, that is being tested in the United States that is called F-MODI in Europe and more generically Chronocort. And what is shown here on the top left in panel A is just a cross-section of a pill and how the product is constructed with a coating that allows for a different type of release into the bloodstream after the pill is taken by mouth. And if you go down to the bottom here, B, you will see again a almost 24-hour clock here, in which superimposed on the normal levels of cortisol shown in gold, you see the effect in blue of 2 doses of this F-MODI chronocort indicated by the arrows, and they're sort of superimposable due to the fact that there is a delayed and sustained effect of this version of hydrocortisone that is provided. And if you happen to have CAH and and one measures what's called 17-hydroxyprogesterone as a marker of the control of the condition, if you're taking standard hydrocortisone, your levels of this intermediate are in the dashed line. If you are taking the new form, the F-MODI chronocort, your levels are down on the bottom, this sort of horizontal blue line buried within the gray, which is the normal range. So you get quite a bit better control, at least in this research setting. Now, although I'm not recommending this, there are patients out there whose adrenal insufficiency really severely affects their life, and they try all of the standard ways of doing things, and they just cannot feel right. And so some have tried what's called continuous subcutaneous hydrocortisone by infusion. This involves the use of an insulin pump, but instead of putting insulin in it, you put hydrocortisone in it, and this enables a better absorption right into the fat of the individual under the skin, and also allows for bolusing because there's multiple settings that you can deliver at, and you don't have to then have to take Solucortef. And then there's a newer formulation of hydrocortisone. It's called the Alkindi Sprinkle, which is these capsules filled with very low doses of hydrocortisone, which can be very helpful in babies with adrenal insufficiency, usually due to CAH. And this can be dissolved in or put into a little bit of applesauce or yogurt and taken by mouth or put directly on the tongue. And this avoids problems with pill splitting, pill crushing, or trying to dissolve in a liquid. There enables low strength options to help avoid over or underdosing, and it provides a way to mask the sometimes bitter taste of hydrocortisone, and the color coding makes errors much less likely. And the newest formulation is called Kindivi, and this is a liquid hydrocortisone that is approved for replacement therapy in patients 5 years and older with adrenal insufficiency. However, it's not approved for use during stress or any other kind of acute event. The reason it's not approved in younger children is because it contains some inactive ingredients that you can see there, polyethylene glycol and glycerin, which can cause sometimes gastrointestinal irritation and resulting in vomiting or diarrhea, which can be more problematic in younger children than in older ones. And then on the horizon, not necessarily anytime soon, is a new way to make medicine, and it's been tried with hydrocortisone on a research basis, which is manufactured by 3D printing that can provide dosing that ranges from 1 to 6 milligrams and is being tested in Spain, actually, and among other places. So stay tuned on that. And then all patients should have something like this, or the one that comes from NADF or other adrenal organization that is, in effect, their emergency letter that provides their regular doses, their sick day management doses, what to do for surgery, and it doesn't matter which one you have, and you can borrow these, modify them as needed, but everybody should have one. And for a child with adrenal insufficiency, what should one pay attention to in particular? Prevention of adrenal crisis is key, and use of extra hydration and possibly hydrocortisone during upcoming stresses can be done. Any illness or injury, since that may precipitate an adrenal crisis in a child with AI, and this needs prompt attention. These include simple fever, GI illness, a fall from a bike, any kind of other moderate injury. And this involves early recognition with administration of extra oral hydrocortisone and fluids, provided no vomiting is present, in which case the injectable form should be given. This is the best chance of avoiding this from process from getting worse and a child ending up in the hospital. And I always say that if you think you should give the hydrocortisone by injection, you probably should. If it crosses your mind, there's no real risk in doing that in case it turned out that whatever was going on was not an adrenal crisis. And I would finally point out, and I apologize, I missed the very end of the previous talk in case this was discussed, but there will be, well, you saw and you know that the administration of Solucortiv is not so easy. And a better system with less steps and even without a needle would be a fantastic improvement. And there are things on the horizon to do this, all of which involve fewer steps and a couple of which involve needleless administration. And these are their names, and I'm not going to spend a lot of time on this, but suffice it to say that these are in various stages of development and testing and are the future. And finally, what should be communicated to schools and caregivers? A book is a great thing, and they exist, but the school needs to know what the condition is, what to look for symptom-wise if the child is getting sick, something about their medication and fluid intake, medical identification, jewelry, a medical alert bracelet, an individual healthcare plan should be provided. This should not be kept a secret. What to do for school trips and sports, exams, getting ready to go to the next school. If the child does have a problem at school, what to do exactly. We all should try to work on legislative guidance to make the life of a child and a patient with adrenal insufficiency better. So I close with this, and I apologize for running over 3 minutes, but just in case you don't know what AI stands for, there's a medicine class called aromatase inhibitors, artificial insemination, aortic insufficiency, of course, artificial intelligence is the big one, and what we hear about today, adrenal insufficiency. I thank you for your attention, and I wish you a great rest of the meeting.
Thank you, Dr. Geffner. Wonderful presentation as always, and we appreciate your time. Unfortunately, we're running over, so we're not going to be able to answer any questions live. But I would encourage you to, for the folks attending, check out NADF's resources. I'm finding out now, I can't remember if it is up online, but we did have a volunteer do a webinar for school nurses. So if it's not up on the site, please reach out to us using the links on the website to contact, and we can see if we can get that over to you, because that's really, really important, that those school nurses can recognize a crisis in a child. So thank you again, and we'll be getting started with our next presentation momentarily.